Thank you, Joe. It's a pleasure to introduce Amrita Salunke. She's one of our newer pediatric gastroenterologists, and we have really enjoyed having her as a partner. She came to us from the Children's Hospital of Montefiore in the Bronx in New York. She did her pediatric residency at SUNY in Brooklyn, where she was a chief resident in pediatrics. She originally graduated from Sri Devaraj Medical College in Karnataka, India. I hope I pronounced all of that correctly. And I'm really looking forward to her talk about eosinophilic esophagitis. Go right ahead, Amrita.
Hello, everyone. Honored to be here, and thank you to give me the opportunity to present today's grand rounds. And without further ado, so what is eosinophilic esophagitis, and why is it the most common disease we have not heard of? I have no disclosures. I will be talking about off-label medications and investigative diagnostic tests, as currently there are no FDA-approved therapy for EoE. So the objectives of this presentation is to define EoE, understand the epidemiology and risk factors, and the pathophysiology, varied clinical presentation, the diagnosis, management, and the upcoming treatments we have in the horizon. Talking about history, this is a relatively new disease. And there's an elaborate 40-year journey associated with EoE. The first initial case reports came out in the late 1970s when it paralleled the rise of fiber optic endoscopy in both pediatrics and adults. But the disease was not classified as a distinct clinical entity until like the early 90s. Moving on, the first population-based studies on pediatric EoE came out of Cincinnati, where they noticed a 4-fold increase in incidence between 2000 and 2003. The first guidelines on EoE did not come out until 2007. In 2008, there was a huge adult and a pediatric pathology database study, which classified the epidemiology, incidence, and prevalence of EoE. And interestingly, the ICD code did not come out for EoE until 2008. So most of the studies which were based retrospective, it wasn't very easy to classify, or search for EoE. They had to use other parameters. In 2009, there was one of the largest pediatric cohort studies came out of CHOP, which I'll be talking about. So what is the current definition of EoE? So eosinophilic esophagitis is characterized by chronic, local, immune-mediated esophageal disease, characterized by symptoms of esophageal dysfunction and histologically by an eosinophil predominant inflammation. Other systemic and local causes of esophageal eosinophilia should be excluded, and the clinical manifestations or the histological data should not be interpreted in isolation. It has to be put in context. Why do we need to know about the current definition? Because in 2007, lack of response to high-dose PPI was actually considered one of the criteria to diagnose EoE. In 2011, that criteria still persisted. However, with the better understanding of the disease, we did know that there is an entity called as PPI-responsive esophageal eosinophilia, which basically means a certain population does respond to PPI. However, we now know that this is not true, and a response to a drug should not be classified as a separate entity, but it is actually positioned as a therapeutic option. Moving on to the epidemiology and associated risk factors. Depending on where the study came from, which center the study was performed, the incidence varies widely between 1 to 20 new cases per 100,000 people. The prevalence ranges anywhere between 13 to 49. Again, it depends at what time the study was done, whether they used the criteria of ruling out EoE by using PPI, in which case the true incidence may be even higher. There is a male predominance in all of the studies which looked at the epidemiology, almost to the ratio of 3:1. We don't exactly know why that happens, but there have been some GWAS studies done which show that there is a genetic susceptibility associated on the X chromosome, which leads to an increased incidence of EoE in this gender. And the incidence of EoE is also almost the same between 0.7 to 10, again, depending on which geographical area the study is coming from. This is a nice pictorial representation, which points to the steep rise of EoE, as a time trend noticed from in population-based studies. As you can notice, the incidence, which was one of the first studies to come out in 2004, looked at the rise of pediatric EoE coming out of Cincinnati and Hamilton County in Ohio. And then something more closer to home from Olmsted County in Minnesota, there was a sudden rise of EoE from the late 90s up till 2005, which indicates there may have been an environmental trigger, leading to the development of EoE. This study was done from Mayo. What they did was they looked at the incidence of EoE by re-reviewing all the esophageal biopsies that had any mention of eosinophils or esophagitis in the 3 decades prior to their study. And what they found was the incidence of EoE, you can speculate, went up in parallel with rise in endoscopy volume. However, the increase on EoE outpaces even the modest increase in endoscopy. If you adjust for increase in endoscopy, the incidence of EoE was still higher. And you can see between 91 to 95, the incidence ranges anywhere from 0.35, and in 2001, it increased to almost 9.5. Similar trends can be seen in prevalence and population-based studies. Again, the same areas, Hamilton County in Ohio, and also studies in Europe. Coming to the worldwide prevalence of EoE, we don't have much data coming out of developing countries, but we do know there's an increased incidence and prevalence of EoE in Europe and Northern America. So one of the speculation is, hygiene hypothesis. There's a better socioeconomic condition, better living conditions lead to development of EoE. Is there less exposure, similar to what we see in asthma and other atopic conditions? This was a very beautiful study which came out and looked at prevalence of EoE stratified based on age. So this group collected data between 2009 and 2011 using a health plan claims database. And what they noticed was that the highest prevalence was found in this age group between 30 to 40 years of age. And as expected, the prevalence is higher in males as compared to females. Which is very interesting because you would expect for a chronic disease, which is non-fatal, the prevalence should typically continue to increase with age. So you can speculate that maybe there was an unidentified early life exposure, probably like a few decades prior to the onset, which may serve as an etiological factor. And the prevalence of EoE in children less than 20 years of age is almost similar compared to adults, with an overall prevalence of 56. So how common is EoE in clinical practice? 7% of adults who have esophageal symptoms end up having EoE, and the incidence increases, as the etiology becomes, or the symptoms become more specific. For example, 23% in all patients who present with dysphagia, and 50% in all patients who present with food impaction. Similarly, in pediatrics, the pooled prevalence for any child who undergoes an endoscopy, the chances of finding an EoE is 3.7%. Goes up to 6% if you're scoping for abdominal pain, and 3.7% if it's an aerodigestive patient. I like this heat map, which looks at the predicted adjusted odds ratio for EoE in each US zip code. Blue indicates, the population density is the chances of having EoE are low compared to red. And as you can see, population density is very strongly and inversely associated with esophageal eosinophilia and EoE. This may be more, relevant in rural areas where there may be more, increased environmental exposures. For example, less populous areas may have a higher exposure to pesticides or herbicides, higher density of, livestock, cattle, higher exposure to plant-based allergens, or, increased exposure to particulate matter. Which is also what we see in clinical practice, that a lot of patients who come to us with EoE come from rural or far off places and not in densely populated areas. So this was an excellent study which looked at the natural history of EoE. It was a nested case control study which looked at the outcome over a period of 15 years. So what they found was they retrospectively identified almost 42 children with EoE and followed them, looked at their current symptoms and found that 73% of patients had persistent symptoms as an adult. Over half of them complained of dysphagia after their first endoscopy. 40% of them presented with food impaction later on in life, and almost 14% of them developed an esophageal stricture. Almost all the patients complained of worse quality of life, and symptoms of dysphagia and food impaction correlated with the peak eosinophil count found in biopsies. What was also very interesting, that for every 10 eosinophils per high power field found in biopsies, the odds of dysphagia increased by almost 1.6. Coming to pathophysiology, this is a nice overview about the risk factors, or probably a combination of all factors associated with EoE. We do know that there is an associated atopy, so seasonal variation. For example, there is an increased incidence of EoE in summer and fall. Oral immunotherapy can also induce EoE. Around 2.7 to 3% of patients undergoing oral immune therapy could develop EoE. Now, whether it simply unmasks EoE in a patient or whether the introduction of a food antigen triggers EoE, it's quite debatable. There is a high rate of atopic dermatitis, seasonal allergies, asthma in these patients. So there is an underlying atopic condition. What about the environment? We do know there are early life factors associated with EoE based on prevalent studies. So cesarean birth, antibiotics, formula feeding, cold and arid climates, and even H. pylori. H. pylori is inversely associated with EoE. Heritability, this is a disease initially was characterized in Caucasian patients. And also there was familial clustering of cases. So most of the diseases initially were found in a common family environment, which suggests there may be underlying genetic risk factor. And we do know from GWAS studies or genome-wide association studies done to look for candidate genes, and they found a number of genes associated or which predisposes a person to develop EoE. And of course, cellular pathology, activated eosinophils lie at the center of inflammation, and with the release of a type 2 helper response, and I'll come to that later in my slides to talk about the exact cellular pathology. Coming to genetics, and I bring this up, there were twin studies done looking at concordance in EoE. because we do know the underlying genetic factors, and not surprisingly, there's a genetic concordance rate around 58% in monozygotes and around 2.4% in non-twin siblings. However, what was interesting was in dizygotic twins, the concordance goes up to 36%, which suggests there's probably a shared twin environment, an environmental trigger with an underlying genetic susceptibility, which predisposes to development of EoE. What are those genes? We do know now: thymic stromal lymphopoietin protein, calpin-14, STAT6, and also epigenetic factors like CCL26 and calpin-14 are associated. So EoE, environment and genes. This is a nice pictorial representation about the risk factors associated and early life factors associated with EoE. We do know, any fevers during pregnancy, they did find a positive association. Absence of furry pets. So if you don't have a cat or a dog, there's less exposure to antigen and increased risk of developing EoE. This is a bit controversial, and I'll come to that later, that acid suppressants, especially used within the first year of life, can predispose to development of EoE. However, acid suppressants are also used in the treatment of EoE, which I'll come to that later. NICU admission, C-section, antibiotics during the first year of life are all positively associated with EoE. We did speak about population density, season and climate, smoking, infections, H. pylori, which is inversely associated. Higher the population density, more chances of having H. pylori, and lesser the chance of developing EoE. Coming to genetic susceptibility, I'm going to pick one example. When they did GWAS studies and SNP, looking for SNP gene associations, they found that if you have an underlying calpain-14 presence, if you have a genetic susceptibility with presence of calpain-14, and if you are breastfed, that decreases your chances of developing EoE. However, if you have an underlying genetic susceptibility with presence of calpain-14 and you're formula fed, there's a higher chance of developing EoE. So if you don't have this genetic susceptibility, whether you formula feed or breastfeed doesn't make a difference. EoE and food allergies. So, EoE can be considered a distinct form of food allergy. However, IgE is not always elevated in patients, compared with someone who has a food anaphylaxis. And we do know based on bench studies that IgE null and B cell null mice can develop esophageal eosinophilia. And more recently, there has been discussion that perhaps it's not IgE, but there is a switch from IgE to IgG4 mediated inflammation. And also interestingly, IgE-based skin testing does not identify food antigen triggers. And we also know that anti-IgE therapy, omalizumab, which is used in atopic condition, is not effective in EoE. There's insufficient evidence to suggest that, if oral immune therapy leads to de novo EoE, or if EoE is accidentally triggered by the antigenic food. This was a nice systematic review done, for looking for associated atopy, which can be present in 50 to 60% of the patient. Sensitization to cutaneous and also, aeroallergens can lead to development of EoE. In any cutaneous ingested or inhaled allergens can lead to the development of EoE. So depending on which study you look at, the association of asthma with EoE is somewhere between 26 to 50%. Allergic rhinitis anywhere from 30 to 90%. Atopic dermatitis, probably half of the patients have those. And IgE food allergies present only around 9 to 24% of the patients. Coming to the cellular pathogenesis, it looks a little busy. I can walk you through it. So there is an environmental trigger in the form of a food allergen, which could be milk, egg, wheat, or any microbe, which triggers a type 2 helper response. This is modulated by certain genetic factors like TSLP and IL-33. A T2 response leads to secretion of IL-4, IL-13, IL-5 cytokines, which in turn lead to activation of downstream signaling with STAT6, and also transforming growth factor beta. Transforming growth factor beta is associated with fibrosis, which in turn can lead to remodeling of esophagus, which is what we see in clinical practice as a fibrotic esophagus or a person presenting with a stricture or a food impaction. What happens when you have an increased expression of an inflammatory phenotype? Well, STAT6 leads to increased expression of calpain-14 and also leads to decreased expression of desmoglein. Desmoglein is an intercellular adhesion molecule, which, disruption of that leads to loss of barrier and also leads to an increased expression of eotaxin-3. Eotaxin-3 is a eosinophilic chemotactic factor, and this is the most expressed gene in tissue in patients with eosinophilic esophagitis. So at the heart of it lies an activated eosinophil. So clinical presentation, and I'm going to spend some time on it because because it varies widely, whether it's an infant as compared to if it's a child or if it's an adult. So children can present with, very non-specific symptoms: failure to thrive, nausea and vomiting, abdominal pain, heartburn, picky eaters, feeding difficulties. So feeding difficulties, if you think about differential, they could be anything. They could be related to GERD. They could be related to oral motor dysfunction, behavioral issues, oral sensory dysfunction, or dysmotility. So a wide variety of non-specific symptoms. In adults and teenagers, the symptoms kind of become related to the remodeling of the esophagus. So they can present with dysphagia. Symptoms, if you ask them how long does it take for them to finish their meal, they're slow eaters. Inadvertently or subconsciously avoid certain foods. Avoidance of social eating, chest burn, heartburn. And the difference is, it depends on the pathophysiology. So in children, they usually present with a more inflammatory phenotype, and hence the symptoms are more, they resemble GERD, as compared to an older child or an adult who presents with a more fibrotic presentation and a food impaction. And teenagers and older children probably present with a combination of an inflammatory and a fibrotic phenotype. This is a very interesting slide, because patients can alter their eating behavior to compensate for any perceived difficulties in the texture of the food they're eating. For example, in infants, their meal duration may be longer than their brother or sisters. They're, grazers. They come on the table, quickly leave, graze on a small amount of food, and then get distracted and leave. And the coping mechanism behind it is also, if you ask a clinical history, does the child, pool the food in the pockets of their cheek? Does the child spit out food mostly? Is he or she dipping food in liquids? Is there a preference for liquids over solid foods? And most of the time, parents come in with a complaint of, the baby or the infant, they're having difficulty advancing diet from a baby or liquids from formula or pureed foods to solid food, or maybe described as a fussy eater or food refusal, or they may present with feeding therapy or speech therapy. What about children in grade school? If you send them to school with a lunchbox, they may come back with a full lunchbox. They may take longer to eat compared to their friends. Again, subconsciously use a large amount of dips, sauces, or any sort of liquids, prolonged chewing. I did have a child, a 6-year-old, who actually presented with, sialorrhea. And mom's main complaint was that, he's just salivating all this time. So he was probably trying to, masticate or pulverize the food in his mouth by using, trying to make it more edible. Refusal to expand, they have a very limited diet and they refuse to explore new flavors and textures. In teenagers and adults, the behaviors can become more compensatory. There is social embarrassment or of eating out. There's a fear of food being stuck. They may prefer soft textured foods. Some patients may come up that I don't like pills, I like taking liquids, or I don't like to swallow any capsules or pills. There's also a history of trying to drink a lot of water with food to help it flush down. And also a subconscious avoidance of certain foods, like they may avoid meats, bread, rice, fruits, corn. So something to keep in the back of our mind. This also plays a role during research studies when we use patient symptoms questionnaire, because there may be a lot of adaptive behavior which may compensate and may give a false impression of having no symptoms. I liked this mnemonic, so hopefully this slide makes an impact. So if there's anything to remember of, what questions to ask, during the clinical history is kind of summarizes very nicely here. So imbibes or takes more fluids with meals, food modifying behavior, prolonged meal times, avoiding hard textures, chewing excessively or for a prolonged period of time, and turns away pills and tablets. Coming to a diagnosis, so EoE is still a histological diagnosis. So we do know based on the clinical symptoms, definition, you do need to have symptoms of esophageal dysfunction, histology, which shows more than 15 eosinophils per high power field, and no other potential etiology or associated conditions which could explain the presence of eosinophils. Endoscopy is done typically off PPI, and the ideal time is minimum 4 to 12 weeks off PPI. However, this may not be always clinically possible. So if a patient who's very symptomatic and definitely needs PPI, the endoscopy may have to be done on PPI, keeping in mind that the results may be normal. So what are those modulating factors? For example, a patient who has underlying atopic conditions like asthma, seasonal allergies, and if received a dose of oral steroids, that histology may not be conclusive. We do know EoE could be patchy, so your histology is only as good as your sample. There is a seasonal variations. We can have patients whose symptoms are triggered only in certain seasons, for example, fall or in winter, and even if they keep the same diet throughout the year. And also dietary restrictions, if there is an subconscious restriction of diet, because they do know that triggers symptoms, you may have a normal endoscopy. So what are the associated conditions which we need to rule out, which may present with esophageal eosinophilia? EGIDs are eosinophilic gastroenteritis, and I'm not going to talk about them, but you can have eosinophils in the stomach, the small intestine, and colon. IBD is one of the major things, especially Crohn's disease, which can present with eosinophils in the esophagus. Any parasitic infection, pill esophagitis, especially with doxycycline, can present with eosinophils. We also see esophageal EoE in solid organ transplant patients, which I will not be talking about today. Drug hypersensitivity, and also genetic conditions and hypermobility syndromes like Marfan's and Ehlers-Danlos, which they found have an underlying similar genetic abnormalities as an EoE. GERD, so GERD is a big factor. GERD is a main differential to consider, and I'll talk more about it because ruling out GERD was one of the criteria when we initially defined EoE. Achalasia, again, any skin conditions like pemphigoid and graft versus host disease. So EoE and GERD, there is in the last decade, I would say there's a better understanding about the pathogenesis of EoE, and GERD and EoE are not mutually exclusive disorders. they can coexist in the same patients. Hence, the idea of using PPI to rule out GERD was taken out. We no longer do that. So what happens? Is it the chicken or the egg? Does EoE lead to barrier disruption? There's an inherent baseline barrier disruption which leads to acid hypersensitivity, or is it GERD causing, erosive esophagitis, causing barrier or disruption of the mucosal integrity of the esophagus, leading to permeation of any food allergen and triggering an immune response? Both of these theories are unproven; they're only speculations, but they can coexist. Coming to endoscopy, so like I said, EoE can be patchy. So the best sensitivity of diagnosing EoE is when we take minimum 6 biopsies, so 2 from distal, mid, and proximal esophagus. Ideally, biopsies should be taken from the area of pathology. So if you see inflammation in the esophagus, that is where you should be aiming for. However, keeping that in mind, almost in 10 to 32% of the patients, the esophagus can appear normal. So which emphasizes the need of biopsies even in a normal appearing endoscopy. There was a study which came out a few years ago which said that African Americans have a higher chance of having a normal endoscopic appearance, again reinstating the need for obtaining biopsies even though everything looks normal. The accepted threshold for eosinophil density is 15 eosinophils per high power field. And where did this number come from? Based on studies which showed that the sensitivity goes up to 100% if you use this threshold. We do know that the esophagus is not supposed to contain any eosinophils, as opposed to the stomach may have eosinophils, the small intestine may have small number of eosinophils as a baseline, and the colon can certainly have 20 to 30 eosinophils per high power field as a baseline. However, the esophagus should not contain any eosinophils. So some people suggest that any number of eosinophils, even if it's less than 15, is abnormal. Coming to histology, this is a nice, beautiful picture of a normal esophagus, a stratified squamous epithelium, the lamina propria, and the basal cell. What happens in EoE? So you can see there are a lot of eosinophils interspersed in the epithelial layer. There's basal cell hyperplasia as compared to this nice, 2 or 3 cell-lined basal cell layer. Dilated intercellular spaces, and also there's elongation, papillary elongation seen in EoE. However, just having eosinophils is not enough. There was a histological scoring system which was validated looking at other features, looking at eosinophil density, which we know, basal zone hyperplasia, eosinophil abscesses, so clusters of eosinophils lying together, eosinophil layering the surface of the epithelium, dilated intercellular spaces, and surface epithelial alteration, and also lamina propria fibrosis. This is very important because this suggests remodeling. However, not all biopsies may contain lamina propria, so depending on the size of the forceps we use, you may or may not get lamina propria. What are the endoscopic features associated with EoE? This is an esophagus which shows edema. This is an esophagus which shows trachealization or rings, concentric rings in the esophagus. We may see white exudates, the white plaques on the surface of the esophagus. You may see longitudinal furrows, which is also a sign of remodeling, or you just may present with an obvious stricture, or probably a combination of all these. So how do we, explain these findings? So a good objective measure is an EREFS scoring. So every time an endoscopy done, it will be helpful to comment on these 5 features to use as an objective measure. What about an esophagram? EoE usually does not present with a focal stricture. It presents with a narrow calibered esophagus, and they're usually longer, in length. So with a longitudinal stricture. What are the upcoming diagnostic tests? What about genomics? So this was a molecular alternative, which came out in the last few years to traditional histology. When you cannot really make a diagnosis based on histology. We do know that the transcriptome in the esophageal tissues is different in patients with EoE as opposed to patients who have GERD. There are about 96 genes with a sensitivity of 96% and specificity of 98%. And the positive predictive value with EoE was as high as 97%. This study was recently validated, which came out like a couple of years ago, and they found a positive association with eosinophilic count. They found a positive association with the histology score and also with endoscopic ER-EFS scoring. Transnasal endoscopy. So, most of these patients end up with multiple endoscopies requiring anesthesia and sedation. So transnasal endoscopy is a new kid in block. So the first study initially came out of Colorado, and they recently came up with an update where they scoped 190 children. They had 300 attempts at transnasal endoscopy, out of which 299 were successful. So their success rate was pretty high, 98%. There is also, it's also a very cost-effective measure to cost-effective endoscopy as compared to regular endoscopy, which they were able to discuss, which they were able to bring up. More and more centers are doing transnasal endoscopy, more in conjunction with ENT. So this may be the new, this may be the direction we may be moving on in the future. What about distensibility studies? So an endoflip is a catheter which is passed through the mouth, and there's a balloon which is inflated with saline to look for the distensibility of the esophagus. So we do know that when you have remodeling of the esophagus, the compliance and the distensibility of the esophagus comes down. So this study initially came out of Chicago, where they looked at patients with EoE and patients who were treated with PPI, and they presented almost similarly. These are the controls where, as the pressure went up in the balloon, the compliance of the esophagus increased until it plateaued. However, this was decreased in patients with EoE and also in patients who were treated with PPI, suggesting that remodeling is the main complication associated with EoE and may be used as a secondary end measure. What about in children? There was a study which came out of CHOP and found similar results as in adults, where they scoped 88 patients with EoE and had an endoflip placed, compared with 44 patients who did not have EoE, and they found a positive association of decreased distensibility and compliance in patients who had eosinophilic esophagitis. What about non-invasive testing? There's a lot of research going on to move on from repeated endoscopy procedures to something more non-invasive. And one of them is an esophageal string test. This recently came out in the market, and it's known as the Entro Tracker, which comes in with the esophageal string test, which looks at eosinophil-derived proteins in the transcriptome. So the first study came out in 2013 out of Denver, where they looked at 41 children. So what they do is there's a capsule with a 90 centimeter of string, kind of put together inside the capsule, and you swallow the capsule while keeping some amount of the string outside the mouth. And then the initial studies were done with an overnight placement of the capsule, and the most recent study came out by using the capsule for 1 hour. So after the study is done, the capsule is taken out, or the string is taken out, and the secretions are analyzed. And they found good studies and good correlation. This was the most recent study which came out last year, and they found, the ROC curves had a pretty good sensitivity and specificity in identifying EoE. It needs further validation in pediatrics, but this will be very helpful in patients who the risks of doing a procedure are higher, but you still have to do repeated procedures to look for histological remission. What about treatment? It's a multidisciplinary team consisting of a gastroenterologist, an allergist, and a nutritionist. A feeding therapist may also be involved if the patient is younger than 2 years of age. There are three main lines of treatment. We have pharmacological and non-pharmacological, and then we have endoscopic treatments. Pharmacological involve, anywhere from PPIs, steroids, leukotriene antagonists, mast cell stabilizers, biologics, and even small molecules. And dietary therapy is the one which has been widely studied, and I'll be talking more about that. So where should we begin? What should be the initial therapy to start with? There are no right answers. It depends on, how good is the efficacy of the treatment being administered. Are we using an elemental or an amino acid-based formula, which has a good efficacy of 90%? Are we concerned about adherence? Is this a teenager who may not be willing to do a diet therapy because of, quality of life issues? Is the treatment based on parental or patient preference, and how severe is the disease? Does this esophagus have a stricture? Do we need to think about dilation first before starting even a treatment? And also resources for dietary therapy, because elemental formulas can be expensive. And of course, insurance always plays a role in deciding what treatment should be instituted. So it's a shared decision-making between the patient and the treating physician. What are the goals of treatment? Symptomatic relief, histological remission. However, that being said, symptoms do not always correlate with histology. So you may not have any symptoms, but the esophagus may still be inflamed. Again, emphasizing the need for endoscopy anytime a treatment change is done or any dietary therapy is changed. An ideal goal will be reversal of the endoscopic features. So, no more concentric rings, resolution of furrows, treatment of strictures. And again, fibrosis is another endpoint to look at. We can do an esophagram to look for resolution of the stricture, or an endoflip study, which we spoke about, to look at the distensibility or compliance of the esophagus. Quality of life is a major issue. Most of the patients, especially teenagers, may have a very restricted diet, which may play a role, which may affect their adherence, especially when they move on to college. So probably a combination of multiple therapies like dietary plus PPI or steroids plus PPI may be better at achieving, different endpoints. How do we classify response? We do have pretty straightforward. You have complete normalization of the esophagus. The biopsies are normal. We don't see any eosinophils. Symptoms, there's 90% decrease in symptoms. And there is the endoscopy looks absolutely normal, and the stricture is completely resolved, pretty easy. Or you're a non-responder, still have eosinophils in the esophagus, still symptomatic, still complains of dysphagia, and the endoscopy still shows findings. What happens when you partially respond? What do you do in those cases? What do you do if you have eosinophils ranging between 1 to 6 or 7 to 14? Or there is some decrease in symptoms, but no complete resolution. So then it becomes more of a decision is based on a case-by-case basis on what should be the next line of therapy. So moving on to PPI, as we discussed, PPI responsive esophageal eosinophilia, the term has been eliminated. Responders to PPI are actually part of an EoE continuum because they show overlapping, phenotypic features of EoE. This just came out in the AGA technical review and AGA guidelines on treatment of EoE in both adults and pediatrics. And they looked at 23 observational studies and found that PPI by themselves, high dose PPI, which is 1 milligram per kilo used BID, can actually lead to histological response in 42% of the patients. However, the strength of the recommendation was was conditional and based on very low quality evidence. And the reason being, most of the initial studies, before 2015, were done when patients who responded to PPI were actually excluded. So we may have excluded, patients who actually did respond to PPI and actually did have EoE. This was a nice study which came out of Spain, where they did a prospective study in children and treated them with high-dose PPI and found that 68% of children were in histological remission at the end of 8 weeks. When they extended the study, they found that 71% maintained their histological remission. So 71% of the responders maintained histological remission on 1 milligram per kilo per day dosing of PPIs. Interestingly, they were able to predict which category of patients will respond better to PPIs compared to patients who may not. So esophageal microRNA was used, and depending on which increase in expression or decrease in expression, they were able to delineate responders versus non-responders. So this may be, moving on the next few years, EoE will be will be treated on the basis of personalized medicine or precision medicine, and we will be able to predict, who is a correct candidate for PPI versus who is the right candidate for topical corticosteroids. Steroids are the most commonly used therapy in EoE, and this was the only therapy in the AGA Joint Task Force guideline to receive a strong recommendations. And as you can see in this review of studies, most of the patients responded to steroids. However, almost 1/3 of them failed histological remission. The side effects were not that significant. That risk of having side effects with corticosteroids was 43% versus 36% in placebo, with a relative risk of 1. That being said, there are a few studies coming up which show, apart from having, oropharyngeal or esophageal candidiasis, there is a risk of, pituitary, hypothalamus pituitary axis suppression. There is some talk about doing cortisol levels if you anticipate long-term steroid use in these patients. What topical corticosteroids do we use? The initial studies were done on fluticasone, so inhaled fluticasone, which produced remission in around 48 to 49% of patients. And then came oral viscous budesonide. So this was a placebo-controlled, randomized controlled trial done in 24 children. And they found, good results with swallowed budesonide. And they used Splenda or sucralose as a delivery vehicle. So they found the remission rate of 87% with this therapy. And what happens if you do not want to use Splenda? Well, we have another option with Neocate Nutra, which is a hypoallergenic powder. And they found this could be used as a delivery vehicle as well. So what happens is you use a respule of budesonide, 1 or 2 respules, and mix it with either 5 packets of Splenda or 1 or 2 packets of Neocate Nutra to produce, a very thick viscous slurry, and swallow it. Should these patients need long-term steroids? There was an extension of treatment done in a double-blinded randomized controlled trial in patients from 3 to 30 years of age. And they found that patients who underwent a dose reduction by almost 50% of fluticasone, they sustained their histological response in at least 73% of the time. What happens if you stop steroids? Another study which came out in Switzerland, patients who were in deep remission. Deep remission means you have clinical, histological, and endoscopic remission, no features of EoE. 81% of them relapsed within 22 weeks of stopping steroids. So, that may not be an option. However, decreasing the dose, as I mentioned in the other slide, may be an option. Why do we use oral viscous budesonide as opposed to nebulized budesonide? We do know that the contact time with esophagus plays a role in the efficacy of topical corticosteroids. And this was a nuclear scintigraphy study done, which looked at, how long the medication retains in the esophagus after ingestion. And this was in comparison to nebulized budesonide, which actually showed increased uptake in the lungs as opposed to the esophagus. So this is the reason oral viscous budesonide is preferred over nebulized budesonide. However, fluticasone is also pretty similar in efficacy. So there was no difference found in the efficacy of budesonide, oral viscous budesonide versus swallowed fluticasone. So the efficacy is dose dependent and not drug dependent. And one of the clinical question is, how do you use fluticasone in clinical practice? You use a regular inhaler, but without a spacer. And the dose is, depending on how old you are, you can use, 1 to 2 puffs of 110 microgram BID, or in an adult or an older teenager, 220 micrograms, 2 puffs BID. Budesonide, depending on which vehicle you use, whether you're using Splenda or Nutra-Neokid powder or honey or applesauce, can be used, and the dose is 1 to 2 milligram in kids as opposed to 2 to 4 milligrams per day in adults. So it's surprising that despite knowing about EoE in the last 40 years, we do not have any commercially available viscous solution of budesonide. So Europe just recently approved an orodispersible tablet or an effervescent budesonide tablet, and the results have been really encouraging. They've done 2 studies, looking at remission rates and also maintenance of remission, and the results are pretty much above 80%. There is a commercial budesonide liquid suspension clinical trial undergoing clinical trials in the US. So maybe in the next couple of years, we may be able to have a commercial preparation of budesonide. Who are the candidate of patients who don't respond to steroids, older age, patients who have atopy, esophageal stricture, prior history of dilation, family history of EoE, or a lower dose of swallowed steroids. And patients who do need long-term maintenance therapy are patients who have, again, small calibered esophagus, strictures, history of food impactions, any comorbidities increasing the risk of repeating endoscopies, or prior perforations. What about biologics? So it's the era of biologics. We use biologics in IBD all the time. So what about in EoE? So if you remember the slide of the pathophysiology associated with EoE related to IL-5, IL-13, we do know that biologics or interleukin-based therapies against IL-5 are not that effective. However, there is very encouraging data coming out of dupilumab, which is a monoclonal antibody against the combined receptor of IL-13 and IL-4. And phase 3 trial results were recently released, and they found a good percentage of histological remission, improvement in clinical symptoms, and also improvement in the distensibility and compliance of the esophagus. Coming to dietary therapy. So, dietary therapy alone can be used to induce remission. There are 3 categories. We can use a total elimination diet. So, just being on an amino acid based formula, or an empiric elimination diet where you avoid the most common antigenic allergenic foods, or a food allergy testing based diet where you do skin patch testing or a prick test or skin prick testing. Food allergies based on allergy testing have not been really successful. There were 2 pediatric retrospective studies done, and they were not replicable anywhere else. However, empiric elimination diet has found some benefit. So we have a 6 food elimination diet consisting of dairy, gluten, eggs, soy, fish, nuts, seafood. We can even do a 4 food elimination diet or a 2 food elimination diet. So the 2 most common foods associated with EoE are dairy and wheat. Again, elemental diet, which is an amino acid based formula, can produce almost 90% remission. However, this may not be the choice for everybody. This is a nice systematic review looking at use of elemental diet, bringing 90% remission rate, as opposed to a 6 food elimination diet, bringing a remission rate of 70%, a 4 food elimination diet, bringing a rate of almost 60%. And dairy by itself, if you have to choose 1 food to eliminate, a 30 to 40% chances of remission, histological remission. Moving on to dilation. Some patients with an esophageal stricture, this may be the first line of therapy. However, we do have to be gentle because if there's a lot of inflammation, there's a high risk of perforation. However, patients who have symptoms of dysphagia may benefit with a dilation first, as opposed to starting them on steroids. Steroids are known to decrease the incidence of fibrotic stricture later on. I like this picture because it shows just how much research and information has come out in the last 1 decade on EoE, as opposed to the early 90s, when we were still trying to figure out what causes EoE. So, advances in genomics and proteomics have led to a better understanding. And I'm not going to go into detail, lack of time. So a nice flow chart to discuss treatment of EoE. So we make a diagnosis of EoE based on histology, symptoms of esophageal dysfunction, and endoscopic features. An allergy referral is done to look for control of environmental exposure and any concurrent allergic diseases. And either of these therapies can be used as a first-line therapy: PPI, dietary therapy for 6 to 8 weeks, or topical corticosteroids. And a repeat endoscopy is done almost like 12 weeks later, 3 months later. If you have symptomatic and histological remission, well and good, maintenance PPI can be started. Or maybe, we can do selective elimination of foods, depending if dietary therapy was started as a first-line treatment. If there are persistent response, or inadequate remission on histology, then things to look out are to rule out, non-adherence, which can happen. Do a combination of therapies. If you're doing topical corticosteroids, add in a PPI. Further elimination of any allergenic diets, eliminate more foods, or switch to a topical corticosteroid. Biologics, like we discussed, dupilumab, maybe the new kid on block, or even dilation. So the summary of EoE, it's a chronic immune-mediated esophageal disease with symptoms of esophageal dysfunction and an eosinophilic predominant inflammation. Symptoms can be very non-specific, especially in younger children, as opposed to in older adults or teenagers. Diagnosis involves endoscopy, and endoscopy is also needed for surveillance of the diseases. Non-invasive testing may be the thing to move on in the next few years, like transnasal endoscopy or the string test. And the treatment, there are no FDA-approved treatments as of now. So whatever I'm talking are all off-label. So PPI, dietary therapy, topical corticosteroids, and even biologics in the near future. Thank you.
Thank you, Amrita. That was really great. Does anybody have questions? I know we're pretty near time. I don't see any questions in the chat or in the questions and answers.
Yeah, I don't see any questions coming in either. In the interest, I do have many questions for you about the patients I see who have EoE, but I know where to find you, so I will do that and not keep the rest of the audience hostage. But that was really wonderful and comprehensive, and I learned about many new fancy GI tricks like string capsules and transnasal endoscopy that I had never heard of before. So thanks for bringing me up to speed, and thanks for everyone for being here for Grand Rounds this morning.
Okay.
Have a great day, everyone.
You too.